Welcome to the Bismarck Cancer Center podcast. I'm your host, Dana Hager, Education Outreach Services Coordinator at the Bismarck Cancer Center. In this podcast, we'll share stories of hope, health, and healing, and learn more about the people and technology behind the scenes at the Bismarck Cancer Center. Today's guest is Dr. John Watkins, Radiation Oncologist and Director of Research at the Bismarck Cancer Center. Thank you for joining us today, Dr. Watkins. I'm so glad you're here.
Thanks for having me.
I know you're busy, but we are so happy to have some time to get to know you and your role at the Bismarck Cancer Center. So first, tell me just a little bit about you.
Sure. I grew up in northern Indiana, about 45 minutes outside Chicago. Went to undergraduate and med school in Indianapolis, did my intern year there, did my radiation oncology training in Charleston, South Carolina at the Medical University of South Carolina. And then after that, I bounced around, did some locums work. I've had jobs in Hilton Head, Alabama, northern Indiana. Actually came up here in Bismarck in March of 2009 as a locums in my last year of training.
Is that what brought you here ultimately?
Yeah, actually kind of a sense of adventure is what brought me here. I never in a million years thought I'd be traveling through, let alone living in North Dakota.
Bismarck, North Dakota wasn't your dream place to end up?
New Mexico was on the horizon. I was thinking sand dunes and heat. And I think ultimately after spending 4 years in the deep South, I was ready to come back to the Midwest. So luckily this opportunity opened up and been here since basically December of 2009.
Okay, so you were here 2009, worked at the Cancer Center. Then I know you took a little break. Mm-hmm. So when was that? You left for a little while? 2014,
the summer of 2014. So my wife transferred from medical school in South Carolina up to the University of North Dakota and graduated in 2013. But she wanted to go into pediatrics, and there's no pediatrics training program here in North Dakota. So she matched at the University of Iowa. I really didn't want to leave because I liked it here, so I tried to do the distance thing for about a year. But we were both cruising in on 40, wanted to get started with a family, and turns out it's hard to do from 2 states away. So I bit the bullet and recruited Dr. Russo to come take my job, and left just as he was starting.
All right. So you went through that. You left us. I'm tears, and I wasn't here at the time, so I didn't have the opportunity to know you then. And then all of a sudden, I started hearing Dr. Watkins coming back. Yep. So what made that decision to come back to Bismarck?
That would again be my wife.
Oh, your wife? Oh, she.
I told her if she was willing to leave the beach for the tundra, then the least I could do is let her decide where we were going to go next. And so as she was finishing up her training, about a year and a half out from finishing her neonatology fellowship, I told her she could pick any job out in the country that she wanted. Worst case scenario, if I didn't like the job offerings locally, then I would just do locums work again, which I had actually been doing locums work up here probably since 2017 during my vacation time from University of Iowa. And so she looked at a couple of different jobs, including one here at Sanford. Ended up being the job she wanted, and luckily there was an opportunity for me to come back. And so I started back up again in full-time in 2019.
Excellent. So we're here, Bismarck, raising a great family. What a great place to be, raising a family in Bismarck,
Absolutely.
North Dakota.
That's what I think it really convinced her to come back here. She thought it would be a great place to raise a family. She grew up outside the D.C. area, and she had no desire to return to a population-dense area where people are habitually mean to each other.
Yeah, we don't have that here in North Dakota. We have North Dakota nice here, don't we?
Yeah, genuinely nice. I mean, some places around the country, people are nice, but it's not genuine. But here in the Midwest, it's genuine. In fact, one time I called her and I considered her an honorary Midwesterner, and she teared up and said that might be the nicest thing I said to her.
You need
which
to
made
say
me
nicer
reflect.
things
Yes,
to your wife
do
if
need
that's
to say.
The nicest thing you said to her.
Wholeheartedly agree. That was a source of introspection for me.
So you have been all over at different clinics or cancer centers all over. Tell me about the Bismarck Cancer Center and your feelings about working here.
Yeah, no, I consider in terms of community-based practices, it's in the top 5 of ones I've ever seen, not let alone practice at. It's the top one that I compare all my other practices against everywhere I've been. I mean, from, the amount of staff's involvement in patient care, wraparound services that are offered, the quality of the medicine that I'm able to practice here, it's head and shoulders above anything else.
That's amazing to hear.
Yeah,
here in Bismarck, North Dakota.
It's a unique and special facility. And I think the patients that have been through our doors understand it, and most of the people in the community and the family members understand it. But yeah, people outside the state, I think, don't really appreciate how truly unique this cancer center is.
Excellent. I want to talk a little bit. Your title, you're not only a radiation oncologist at the Cancer Center, you are also the director of research. Tell me what that title means. What do you do as the director?
So when I first started here in 2009, I'd come out of my training with a fair degree of research experience. In fact, I was gearing myself up for an academic career. I was even offered kind of a dream job doing head and neck radiation oncology at my alma mater, Indiana University. But for a variety of reasons, including me having met my wife, I decided to stay local and ended up practicing in mostly community settings, with the exception of the 5-year hiatus down at the University of Iowa where I was doing research. And so during my time up here from 2009 to 2014, we were pretty actively involved in research with then Med Center in St. Alexis. And we were producing probably about 3 to 4 published papers a year, presenting at conferences on about the same scale. A lot of prostate cancer projects, mentoring medical students on healthcare population demographic studies with the registry, also some breast cancer projects. And so then I continued that. In fact, during my time down at University of Iowa, I would collaborate with the radiation oncologists that were up here to continue to expand on what we had built. And so as I've returned, we're trying to kind of pick up the program again, both including and mentoring medical students, as well as providing an opportunity to kind of promote what we know to be very good outcomes that we have here in this area. And so that's kind of where we are.
Yeah. So your research papers that you publish, you're collecting the data. You're doing all
historically, it's always ideal to have an intern or a medical student to help with the labor. But yeah, historically, most of the data collection I've just done myself in off hours or in between patients, and tracking outcomes, demographics, toxicities, and trying to contribute to the medical literature to help patient outcomes.
It's something you're obviously very passionate about.
Yeah, I think this is the only way we can move our field forward is by figuring out what we do well, how we can do it better, and potentially contributing for others to kind of make that advance forward, knowing what doses certain organs can take without inducing toxicity or specific unique things that maybe we do slightly different than others that maybe have a positive impact on outcomes. And so the more we can share that, the better outcomes for everybody nationwide.
And so is this kind of the way you help yourself keep current too, or how are you keeping current on all the changes and trends?
Sure, yeah. I mean, most of us will have a routine or a way of keeping current with medical literature, series of journals that we follow, the big ones being New England Journal or JAMA or Lancet. But I found that doing clinical research actually helps me kind of get into some of the more nuanced areas of our field that don't quite hit the headlines, the art of practicing radiation oncology as opposed to necessarily the science that most of us already are aware of. And so, yeah, kind of refines your technique over time.
Is this something, do you feel oncologists as a general rule are really into the research, or is this something special for you? Because I know you're kind of into researching all different types of things.
Sure.
You're into everything from financials to taxes, insurance, you name it. Is that special to you, or is that kind of
I don't know.
across the board?
I think anybody in any professional setting probably has a certain desire for continual self-improvement. And so for me, whether it's learning about tax preparation or insurance so I can make sure my family and my coworkers, are protecting their families, or distance running or practicing radiation oncology, it's all kind of a process of self-improvement. And so some part of it's are unique to me, but I think most of the professionals that I meet, whether it's medical oncology, surgical oncology, radiation oncology, they hold themselves to a certain standard, and that's important because otherwise you're just going through the motions and there's no real initiative to improve upon your craft. Absolutely.
So the research that you do, the papers that you do, to lay people, could they understand them? If I were to pick one up, which I have not, I don't know if I intend to, I don't think I do. If I were to pick one up, would I be able to understand anything in there?
I would hope so, but I don't know. I know that I have a tendency sometimes when I write as opposed to when I speak to use fancy words for lack of a better. So As I'm sure many people in many professions, my parents are very proud of me. And so I send my mom my articles.
Sure.
And she tells me that she can sometimes understand them. And she's
and
a non-medical person.
Great, right?
Yeah. My mom's a retired travel agent, so she's not a medical person. And so I would hope that people could, but I try to whittle it down when I'm presenting, either at a conference or even we've done Oncology Nursing Society presentations. And so I try to tailor the talk to the audience. For example, UND Grand Rounds will give sometimes, which is oriented more towards nurse practitioners, physician assistants, and primary care providers. For those folks, I'll whittle down on some of the radiation oncology technical jargon that our therapists or dosimetrists or physicists would understand. And so just kind of make sure you tailor your talk to your audience, I guess.
Excellent. Excellent. The Cancer Center has brought in new technology as of recently, some really cool things to help our patients minimize side effects and just have a better treatment experience. Can you share some of the highlights with us?
Sure, absolutely. I think that's one of the things that helps the Bismarck Cancer Center stand out from other community-based radiation oncology practices. From everything from, we have opportunities for what's called a breath hold technique. So as you can imagine, when you're treating something, say in the abdomen, the chest, or even the breast, it's moving in real time as you're treating, as the patient's breathing, and you can't realistically expect a patient to hold their breath for really more than 20 or 30 seconds. And oftentimes our treatments last about 5 or 10 minutes. And so by using what's essentially a motion capture technology, we can have the beam turn on and off, the X-ray beam that's actually delivering treatment, turn on and off in real time as the patient breathes in or out of position. And so if they're doing a breath hold, maybe they can hold it for 10 or 15 seconds, and then they need to take that breath. The machine will detect that and stop the beam in real time. Patient can catch their breath, take that breath in again, and then hold it, and allows for more safe and more precise delivery of treatment.
So is this something you have to prompt the patients to do, or is the
there's a bit
technology
of coaching? Yeah, there's a bit of coaching involved. So that way, because no patient wants to be on the table for an extended period of time. And so we try to help them understand how the technology works. And even there's some feedback where they can see where their breathing is in relation to, say, a little bar.
So they're taking an active role in their treatments every single day when they're there.
Which I guess is kind of empowering. I have had some patients say that they kind of like knowing that they're involved, and I help explain to them, why it's important. If the less of them I have to treat of their body that I have to treat, the safer it is, the lower the risk of side effects, and the more certainty I have that I'm hitting what I'm aiming for.
And that is new to the Cancer Center. That's something that's just brought in as of...
I think within the past 2 or 3 years.
And pretty common, most cancer centers,
no,
radiation?
Not community-based. Most academic practices, Mayo Clinic, for example, would have something like this, but this is not something that's fairly common in a community setting. So it's fairly unique.
Were you instrumental in bringing that in, or who decides what technology? Because technology has to be changing all the time.
Sure.
Who decides what the Cancer Center needs and how we're going to move forward with acquiring new stuff?
Yeah, I think it's a feedback loop. The clinicians identify, patients who might benefit from specific advances in technology. We provide that feedback to our leadership, try to make sure that it's financially viable, because we don't want to run the Bismarck Cancer Center into the ground. We want to stay above ground.
Well, yeah, that'd be great.
And so I think it's a communication process. And once we've identified a potential to improve outcomes, reduce patient side effects, that's going to impact the most of our patients, then we'll implement that.
It's kind of a no-brainer. Bring
Absolutely.
it in and help the patients out.
Absolutely.
I hear all the time how the Cancer Center is definitely very patient-focused.
Absolutely.
And for you, tell me your favorite thing about that, like as far as thinking of the patient first.
Sure. I think you can look at the wraparound services, survivorship care. We've got our reach coordinator, our social and spiritual counselor. We've got nutrition on staff, massage therapy, physical therapy in-house. These are things that are fairly uncommon. Most of the community-based practices that I've covered are fairly limited. You're talking 2 therapists, maybe a nurse, and a registration desk, and that's it. And then the radiation oncologist. And so to have this amount of wraparound support to make sure that the patients not only continue and do well during treatment, but thrive after treatment is pretty unique and special. And so
you as a doctor being able to I suppose you help explain all these services to the patients too. How do you feel being able to tell patients, I can help you with that?
I'm proud of it. It's proud to be part of an organization that prioritizes patient care and outcomes. And so I I make sure that they're aware that the services are there, although I think our staff does a very good job of explaining to them what's available and why, but it can be a lot, overwhelming. And so something might slip through. I think this patient's going to benefit from this service. I need to make sure that it happens. But honestly, the staff does such a good job. It's a rare situation where I identify something that hasn't already been met.
Awesome. Tell me how you interact with your patients. Is it something, do you get to know them? Do you joke around with them? Is that your comfort zone?
Yeah, I mean, everybody's got a different personality, so you got to be careful. It's a stressful time for people, and everybody processes stressful situations in a different way. But if I get the feeling that they're pretty relaxed, then it's certainly more fun for me to be myself and joke around with them. Alternatively, if it's a stressful time, they're going through a tough time, I let them kind of express their concerns, make sure that they feel that whatever it is specifically that's they've identified as a source of stress that they need to work through, that we provide them the opportunity or the outlet to get work through it, I guess. And
Excellent.
So, yeah.
I can tell that you're in the right place. The patients,
so.
You'll be a good doctor for the patients just by listening to your empathy and your knowledge and what you're able to bring to the table is excellent.
Well, thanks. I think it's the least we can do is to try to treat our patients as though they were our family members. So,
before you became a radiation oncologist, did you know that's what you wanted to do?
Oh no,
Or what?
I didn't even know it was a field until I was nearly almost 70-80% of the way through my medical school training. So,
that's not. I've talked to a few other people on this podcast, and in all different areas of the cancer center, and that seems to be kind of a trend that, hey, I didn't even know that this was an opportunity for a career for me.
It's true.
Until later on.
Yeah, no, I actually I was planning on a career in sports medicine just because of my background as an athlete, and so I kind of happened into it because I realized that I preferred to work with a more motivated patient population than I would see in the sports medicine world, which sounds paradoxical, but it's real.
Yes,
so,
I see that.
It was a medical oncologist at Indiana University, a fairly famous one, Larry Einhorn, who I was shadowing, or not shadowing, I guess it was on a rotation with. And he said, well, why don't you go downstairs and spend a day with the radiation oncologist? And I knew we'd been sending patients for radiation therapy, but at that point, to me, it was, a tech with an x-ray gun in the basement. I didn't know it was like it's a medical field unto itself. And so, I just fell in love with it. I mean, the continuity of care you get with your patients, the combination of technology, applied anatomy, procedures, seeing the patients. And so I married all of my interests and haven't looked back since.
The rest is history, as
That's
they say.
right.
That's
right.
It is. Before I let you go, anything else you want to add and let anybody know about the Cancer Center, about yourself? I know you're an avid runner. I should give you a plug that your team won the Bismarck Marathon.
Our team won.
Well, I think it was your team. I really saw your competitive side getting ready for the marathon. You were figuring out who was going to run, and congratulations.
I just want to make sure that people were where they were supposed to be, or you'd show up and they'd have nobody to hand the baton to.
Well, you did great.
You might be in for double the effort you have planned on.
And you got to beat it next year, so you got time to think about it and get ready for it. But yeah, I know you're super busy. You're competitive. You're active. You got little kids at home. Anything else you want to add and let us know about you?
No, we're happy we moved back. The kids are doing great in school and no regrets.
Awesome. Well, we are so grateful to have you at the Bismarck Cancer Center, to have you back again at the Bismarck Cancer Center. And thank you for joining me on this podcast today.
Thanks again for having me.
Thank you for listening to the Bismarck Cancer Center podcast. Subscribe to hear new episodes anywhere podcasts are found, and connect with us on Facebook, Twitter, or bismarckcancercenter.com. We'll talk again next time on the Bismarck Cancer Center podcast.